but also thyroid disorders are very, very common, and they often show up in the exam. Inshallah, I intend to make this presentation concise and also high yield for, inshallah, our junior doctors, so that they can benefit for exam preparation purpose, but also for the general knowledge. So it will be about 30 slides, and it will be 1 minute per slide. So fasten your seatbelt. Inshallah, it's going to be very quick, inshallah, presentation. Okay, so the first slide, it speaks about the relationship between the thyroid gland and the other glands. So the thyroid gland is in the neck, but it doesn't function on its own. It's influenced by the hypothalamus and the pituitary gland. So in brief, you have the hypothalamus have a positive influence on the pituitary gland through the TRH, and then the pituitary gland would release the TSH, is very important hormone, thyroid stimulating hormone. That hormone goes to the thyroid gland and induces the gland through the TSH receptor to produce the thyroid hormones, mainly T3 and T4. Remember, T3 is the biologically active hormone. T4 is act like a reservoir or a precursor, basically. But it's important to measure sometimes both, and we'll talk, inshallah, in details as we go through the presentation. This presentation, inshallah, will be more clinically what you're going to see in your general practice. As a general pediatrician, remember, when you have a child who has slowed down in the height, always remember differential diagnosis, a long list of differential diagnosis. But among that differential diagnosis, remember, hypothyroidism can cause slow down or deceleration of growth. So in this case, inshallah, we're going to go through the presentation. So seen locally for family concerns because she had stopped growing and was gaining weight, reassured by the local physician because of familial short stature. Seen by the psychologist, given antidepressant. And then in the review of system, you have a symptom of constipation. Always feel cold. So there is a cold intolerance problem, and there is some sleep problem, dry skin, and eczema. So this is a typical case of hypothyroidism. Remember, in children, hypothyroidism not always presents like in adult hypothyroidism. So growth failure is a major manifestation. You have a TSH of 252. That's very out of range. So you have up to 5 for the TSH that's considered to be normal. Some they say 4.5, but let's call it 5. And so if you have a combination of TSH being high, and then you have free T4 being low or total T4 being low, in a simple terms, that usually defines the biochemical diagnosis of hypothyroidism. So remember, when you want to diagnose hypothyroidism, you look at the clinical picture, and then you look at the labs, the biochemical diagnosis. So let's speak about the common symptoms associated with hypothyroidism. You have mostly vague symptoms. Remember, hypothyroidism symptoms, they can overlap with a lot of other illnesses. So just lethargy, we can say weight gain, but I would say rather difficulty of losing weight. That's usually in older children and adults. So weight gain, let's call it weight gain, but also difficulty losing weight or maintaining weight in older folks. Headache, very vague symptoms. Cold intolerance, I would say that's a little bit more specific. And then sleep disorder, somnolence, feeling sleepy and tired, and then poor growth in younger children. Constipation is very, very common with hypothyroidism. And then in females who are at the menstrual kind of age, they may have some irregularity, myalgia, and depression are also symptoms. Now, signs of hypothyroidism in your clinical exam. Goiter, not always present, but remember, if you have symptoms of hypothyroidism and then you have an enlarged gland, it's likely going to be hypothyroidism. It's not always present goiter. Alopecia, the hair is usually coarse, sparse. Remember, hair problem with thyroid disorder, it could be association, but not as a causation. It means like the hypothyroidism may not be the direct cause of the hair problem, but there is kind of autoimmune alopecia along with, but take it as an association always. Hair problem with hypothyroidism. Dry skin, usually patches of the skin, they become very dry, or the whole skin becomes very rough and dry. Brittle nails, and then sluggish reflexes. When you do your exam, usually the reflexes are delayed. And if you want to be more specific, it's the delayed relaxation phase of the knee reflexes. So you have the upstroke and then the downstroke, or we call it the relaxation phase, that usually get delayed. On the right side of your slide, you see that bradycardia, depression, psychosis, and pretibial edema. I would say they can be signs, but they are usually the signs of severe hypothyroidism. They don't happen in the hypothyroidism that we often see in the clinic. We see it in the severe cases. Think about conditions that come along with hypothyroidism or cause actually the hypothyroidism, or you can say the classification of hypothyroidism. It's either congenital. This one is very important to diagnose early because it's one of the commonest preventable. It can be prevented. Preventable cause of intellectual disability. If it's misdiagnosed in the first 3 months of life and no treatment, then the outcome is really bad. It's intellectual disability. So congenital, that can be a genesis or ectopic. Either the gland is not formed, has not been formed, was not formed in the first place, or it is ectopic. And ectopic can be anywhere in the midline. So it could be in the posterior tongue, it could be below in the cricoid area, it could be in the upper mediastinum, it could be even in the inside the chest, in the mediastinum. So ectopic thyroid. Dysharmonogenesis is also one of the causes. Remember about the acquired thyroid destruction. So the gland, okay, no congenital problem, but you have an acquired that usually happens in older children and in early adulthood. So autoimmune process is very, very, very common. Hashimoto's thyroiditis is a very common disorder. Also remember that the thyroid hormones can be lost in fluids. So in condition where you have protein losing enteropathy, there is lymphatic leakage, there is nephrotic syndrome, there is chylothorax. Remember these babies who come from these cardiac surgeries, and then they have problem with their lymphatic drainage, and they have like a drain. Remember that drain takes liquids out, but also they take some proteins that contain thyroid hormones. And so hypothyroidism can be profound. Many people don't realize that, but hypothyroidism can happen in these kind of cases, and also in ascites. The treatment of hypothyroidism is by oral replacement. You can give IV, but always oral is simple and easy and the best way to go. You use IV thyroid hormone replacement in cases of critical care where you cannot use oral replacement. There is no enteral feeding. In that case, you can use IV. And remember that the dose, it's per kilo, and the per kilo dose decreases with age. So it's kind of opposite. So the younger the infant, the more per kilo dose. And use the TSH as guide. So the TSH signal, if it's elevated, it just tells you that the body still needs more of the dose. And I know this is going to be up to the endocrinologist to kind of manage that, but I want you to know the basics of how the endocrinologist kind of gauge their treatment. The use of free T4 and total T3 is the way to know adequacy of replacement in case of central hypothyroidism. And remember, when we say primary hypothyroidism, it means the gland itself is not working for whatever the reason is. Primary thyroid disorder, primary hypothyroidism. TSH is almost always high if you have intact pituitary gland. You have another classification of hypothyroidism that's central, which means that there is problem either in the hypothalamus or in the pituitary gland, and in that case, the TSH is of no value. So the monitoring of the adequacy of replacement of thyroid hormone will depend on the hormone level itself, the free T4 and the total T3. As I mentioned, you can use IV levothyroxine. Be careful when you use it. Use it only when needed, and usually in a critical care setting, ICU. And when you give IV levothyroxine, remember the dose is about 50, maybe 75, but no more of the oral dose. So the best way to do the dosing is to do the oral dose, and then after that, you can use 50% for the IV. Okay, let's jump to another topic, or a disorder of the thyroid, and EQ is the abbreviation of the patient. I encourage myself and you to always try to protect patient privacy, so use abbreviations for the names, and I know it depends on the country and the policy of the hospital, but this is why we use abbreviations in the name, EQ. So we have a 7-year-old female presenting to the PCP. PCP is primary care provider with left neck bruising and swelling after falling off her bike. Parents are concerned that the strap of her bike helmet caused the swelling. So you have a 7-year-old, trauma to the neck, but the neck is swollen. We want to know, was it the trauma or was it a gland problem, a thyroid gland problem? So on examination at the pediatrician office, he or she found symmetrically enlarged thyroid gland, and there was tenderness on the left side, not clearly associated with the gland. And then the PCP did an ultrasound that showed symmetrically enlarged thyroid gland. And this one is very important. So the whole gland is enlarged, not one side. The whole gland is symmetrically enlarged. TSH is suppressed. We call it suppressed TSH. So when you have a TSH of 0.01, that's a suppressed TSH because the lower end of normal is 0.3. So clearly there is something going on here, not right. So the free T4 is 1.5, normal, but you can say upper end of normal. So the PCP or the primary care provider decided to take this patient to the endocrinologist for assessment of goiter and abnormal thyroid functions. And that is a very legitimate referral. They did a referral. So I want you to think that way. In endocrine disorders, in thyroid disorder, when you see something, you can just put the highlight and summarize it in one or two lines. Okay, I have a 7-year-old with neck swelling, abnormal thyroid test, and possibly goiter. There is goiter based on the ultrasound. What is the differential diagnosis? So I'll give you like a few seconds to go through this list. Could it be traumatic thyroid inflammation? Could it be bacterial thyroiditis? Could it be de Quervain's thyroiditis? There's a rare subacute granulomatous thyroiditis, and it's usually painful. Could it be Hashimoto's thyroiditis? That is an autoimmune thyroiditis. Hashitoxicosis, that is Hashimoto thyroiditis causing hyperactive thyroid. Or is it Graves' disease? Or is it just an active nodule? Or it could be medication-related thyroid dysfunction. So the way you kind of go through and you rule in or rule out the possibility of differential diagnosis, go through a critical thinking. Go back to the history, check the exam, look at the labs, and then rule in or rule out any of these possibilities. Let's get some more information. So at the endocrinologist's office, we have the 7-year-old with the same problem. We did nutritional history. It's not really helpful, except that she has increased appetite, but there is no weight gain. I think that's helpful. Review of system. There is a little bit of tremor. There is mood swings, sometimes anxious, loose stool, like diarrhea, hair abnormality, sleep problem, cannot sleep, and always tend to be a hot sleeper, means hot or heat intolerance. No prominent eyes and no palpitations or chest pain. So we have a 7-year-old with symmetrical goiter, TSH, the physical exam. We have the pulse, I think is the most important, blood pressure and pulse. You cannot see my screen?
I think this is Dr. Bashir.
Continue, yes, continue, please. We can see your.
Sure, yeah, just a second, sorry. Okay, very good. So that's the rest of the exam. And so let's look at the labs. So we have the TSH very suppressed. It's suppressed 0.03. The free T4 is clearly now out of range, 3.9. Total T3 is 427. The upper limit is 240. And then also the endocrinologist did thyroid antibodies, anti-thyroglobulin antibodies, anti-thyroperoxidase antibodies. All of them are high, but the most important of them is the thyroid stimulating immunoglobulins is also high. Now things are getting, much clearer. And then a nuclear uptake scan that showed increased uptake after at 24 hours, measuring at 69%. So remember now, you have symptoms of hypothyroidism, you have neck swelling, you have suppressed TSH, you have high thyroid hormones, you have positive thyroid autoantibodies, including the stimulating immunoglobulins, and you have high uptake of the nuclear isotope. And so iodine isotope. So that tells you it's the active thyroid, but symmetrically active thyroid. So for practical purpose, you don't have to know about the details of the radioactive iodine, but I want you to know one fact, just one for the exam. 123 isotope is for diagnostic purpose. We don't use it for treatment. We don't do radioactive ablation with it. And 131 is the one that you use for radioactive ablation. So the differential diagnosis, you can now rule out things and you can say it's Graves' disease. It's Graves' disease. It fits the picture of Graves' disease, in which the TSH receptor highly stimulated by the presence of thyroid stimulating immunoglobulins. The gland is symmetrically large and the symptoms of the hyperthyroidism is very evident in this case. So the symptoms associated with hyperthyroidism, nervousness, anxiety, heat intolerance, palpitations, fatigue, weight loss, and tachycardia. I highly suggest that after you finish this presentation, try to read about the pathophysiology of why are these symptoms present in hyperthyroidism? What is the role of thyroid hormones that will cause these sympathetic symptoms? And here also in this slide to your side, to the right side of the slide, the symptoms here are in severe presentation. Not all of them, but mostly the severe presentation, like dyspnea, weakness, diarrhea, anorexia. Eye complaints can happen in basically when there is eye involvement or not, and also the swelling of the legs. But generally speaking, when in the common clinical practice, you're just going to see a young female girl, teenager, who's just nervous and have palpitations, cannot sleep, has weight loss, and tachycardia on exam. Signs: tachycardia, thyroid enlargement, and then you can also hear thyroid bruit by auscultation of the gland because of the hyperactive, enlarged, hyperactive, hyperemic gland. Hyperreflexia can be present. Hair problem, tremors, eye signs may and may not be present, but remember proptosis, the whole eye structure is bulging or perceived as bulging because of the lid retraction. Chemosis is the swelling of the conjunctiva, and there is usually irritation because the eye cannot close shut completely. Atrial fibrillation can happen in severe cases, likewise muscle weaknesses and pericardial. Treatment of hyperthyroidism, you give anti-thyroid medication. Both of these medications, mesamizole and propylthiouracil, they both block the thyroid hormone synthesis. I want you to remember for the exam that for children, there is a black box warning, at least as I know in the US, I'm not sure outside, means this medication has a severe side effect. And the severe side effect is liver damage and the need for transplant. So it's a very serious business. So if you're using treatment for hyperthyroidism in children, and if it's possible to use mesamizole, better than to use the second line of treatment. Radioactive ablation, as I mentioned, 131 iodine treatment. And then surgical treatment, that's the thyroidectomy. I'm not going to go into the details of when you use what, but remember, first line of treatment is medical treatment. And then radioactive iodation, there are some criteria. If met, it can be an option, likewise the surgical treatment. It's important for decision-making to discuss all alternative treatment plans and then make the case for your patient about why we're using this type of mode of treatment rather than the other, to be informative to your patient and help them, and also for medical legal reason. You have to always discuss alternative plans. Medical therapy with mesamizole and propylthiouracil. Remember side effects: rash, hepatitis, cholestasis, agranulocytosis, and others. The one that I want you to remember for your preparation for your exam is two side effects: liver dysfunction and agranulocytosis. These are the two. Any child who is on these medications, they have sore throat or fever, it's an emergency. They must be evaluated and have labs done, because it could be simple fever, but it could be also agranulocytosis that can progress to severe sepsis and problem. So remember, agranulocytosis with anti-thyroid medication, mesamizole and propylthiouracil. And also remember, any jaundice in these children need to also be investigated by doing LFT. So remember, LFT, CBC, when they come to your office on this medication should be your next best step to do. Radioactive ablation by using 131 iodine isotope, usually through the nuclear medicine and in collaboration with your endocrinologist. Remember, it can also cause thyroid storm, because basically the radioactive ablation is killing the cells that produce the gland, the thyroid hormones. And they already preformed thyroid hormones already in these cells. So when they lyse and they die, gradually, they release the content. And the content called thyroid hormones, so you have a rush of thyroid hormones in the bloodstream. And so it can precipitate thyroid storm, especially in uncontrolled cases. Local pain, dysphagia, colitis, and cystitis are also reported side effects. And remember, surgical treatment, as I mentioned to you, is an option, usually in large goiter with compression symptoms, or on those who fail medical treatment or they have severe non-compliance. Sometimes we have to go to surgery. But there are some precautions about outcomes, complications. Hypocalcemia happens because when the surgeons remove the thyroid gland, sometimes they try their best to preserve the parathyroid glands, but sometimes they cannot. And so parathyroidism can happen, and then the manifestation of that will be hypocalcemia. That is sometimes really hard to replace and manage. And so it's very important to be discussed as a potential side effects, a complication of the surgery. Hoarseness of the voice, remember, it's usually due to recurrent laryngeal nerve damage. It's a very common surgical complication of thyroidectomy. Thyroid storm, the surgeons, they can manipulate the gland to remove the gland, and that squeezing and manipulation of the gland, especially if the patient is not well controlled, thyroid activity-wise before the operation, this can make leak of these preformed hormones into the bloodstream, and this also can also induce thyroid storm, hemorrhage. It's also a side effect. I will do some additional slides, and then whenever the time ends, we will finish. I have very helpful slides, inshallah. Medications associated with hypothyroidism. Remember, dopamine, steroids, octreotides, somatostatin analog, they suppress the hypothalamic pituitary gland drive, and then they can cause hypothyroidism. Not directly, not very profound, but in the chronic long term it can, and they can show up in the thyroid test abnormality. So remember, if you have a NICU baby, an ICU baby, or ICU child who is already on dopamine for other reason, and you do thyroid test, they can be off. Why? Because the TSH suppression of the as a result of these medications. Remember, lithium that's usually used in bipolar disorder can cause hypothyroidism through reduction in the thyroid hormone secretion. Iodide, contrast, some of the cleansing, materials, and they contain like the betadine, they contain a lot of iodide, and that can cause the suppression of the thyroid hormone secretion. Amiodarone has a very mixed effect on the gland, a very complex effect, but remember, amiodarone can also cause a long-term thyroid dysfunction, including hypothyroidism, and obviously the antithyroid medications. There are some medications that can affect the absorption of thyroid hormones if it's taken orally. So if someone who already has hypothyroidism and then they're using levothyroxine replacement orally, and then they are also using other medications like this medication that I have here in the list, remember, they can interfere and they can impair the absorption, and so the healthcare provider need to be aware of the interaction. Increased thyroid hormone metabolism means clearance. It gets cleared from the body if someone is already on phenobarbital, rifampin, phenytoin, carbamazepine, all of these anti-epileptics. They induce the clearance or metabolism, let's say, of the thyroid hormone, so it can decrease its function. And so once again, you need to be aware of the interaction. This graph is very helpful if you need to know about CQ thyroid or thyroid hormone levels during illness. Remember, the body compensates and the body adjusts during illness by changing the availability of the thyroid hormone to protect. It's a protective compensatory mechanism. So this graph kind of classify the illness into mild, moderate, severe, and the recovery phase. So in the early mild to the moderate to the severe, you have the TSH, I would say, kind of remains in normal range. So it's not much affected. But if you notice that the free T4 and the total T4 and T3, they take a dive. They gradually kind of get low as the severity of the illness progress. Then they go into recovery. They go back to normal levels during the recovery. The one that's very interesting is the reverse T3. That is a hormone that we measure if you suspect CQ thyroid. I'm not going to go into more details. That's all I want you to know. that illnesses and severe illnesses can affect your thyroid function test. And there is a condition called sick euthyroid. The gland is okay, it's just the illness, the body is trying to adjust and adapt. Low free T4, normal TSH. In a critically sick child in the ICU or have other illness, think about sick euthyroid syndrome. Elevation of the reverse T3, as I mentioned, and it's compensatory, and some people think it doesn't need to be treated, just leave it alone. It's important for those who work in the critical care setting, especially in the cardiac ICU, to know about thyroid disorder in relation to cardiac function. So remember, thyroid hormones, they have positive effect on the heart. So they have positive inotropic and positive chronotropic effect. So if you have someone who has a cardiac dysfunction and at the same time they have undetected hypothyroidism and that they're trying to manage the heart and improve the function without treating the hypothyroidism, that can be also an insufficient management. So always remember thyroid disorder to be, or thyroid function test to be checked in these children. On the other hand, it needs to be well balanced. Over medication by using too much excessive iatrogenic hyperthyroidism, by giving too much thyroid hormone replacement, can also cause tachycardia, can affect also the cardiac function by affecting kind of the filling of the heart. So it needs to be balanced with the illness and the cardiac function in collaboration with the cardiologist. Some of the emergencies or like the severe manifestations of thyroid dysfunction in the myxedema coma. Very unusual now. It's rare because of thanks to the early detection and treatment of thyroid disorder. But from time to time, people will see it. When you have generalized swelling, edema, very cold, dry skin, hypothyroidism, hypothermia, and then lethargy, coma, altered mental status. Think about severe hypothyroidism, bradycardia, hypotension, paralytic ileus, and megacolon can also show up. In that case, remember the treatment need to be aggressive. It needs to be aggressive. You need to go through IV replacement, not oral replacement. With all of this ileus and in the critical setting, oral replacement is not a good idea. So you go with IV replacement with thyroid hormone. Here is the dose for those who are interested. But the general idea, you go IV, you go quick, and then you monitor the effect. So in this case, you do daily and sometimes twice daily measurements of the free T4. Supportive care, temperature, body temperature monitoring is important. Using warm blankets, correct any other physiologic derangements, pay attention to the blood pressure, to the pulse. And also you can use hydrocortisone. It can also be helpful. Thyroid storm. I will take a few minutes in this because it's an emergency. Pediatricians need to know about thyroid storm. It's typical in undetected hyperthyroidism, undiagnosed. Then they come into full-blown thyroid storm. Try to know about the presentation, how it presents, and try to familiarize yourself with the scoring system, because you need to act, but you need to act on objective measures. And so inshallah, I'll detail that in the coming few slides. So remember, surgery can trigger thyroid storm on someone who already has hyperthyroidism. Using of contrast for other reason, for someone who already has thyroidism can also trigger that. Withdrawal of anti-thyroid medication, and then severe stress, dehydration, illness, stress can also, infections, use of amiodarone and use of oral supplementation of thyroid hormones, and hypoglycemia and giving birth. All of these can be triggers. Diagnosis, you have the major kind of manifestations. the clinical manifestation, but you must have elevation of the total and the free T4 and total and free T3. And you must have TSH suppression. So there is no ambiguity. It's clearly hyperthyroid state. You may have some liver injury and abnormality to the white count. You can pull online or in your reference the predictive clinical scale for thyroid storm. This one can, number one, make you objectively make the diagnosis. Number two, you can also gauge the severity. And number three, it can give you a solid rationale for aggressive treatment. Because always, you know, in our clinical practice, this is just a severe hyperthyroidism and I just need to take care of it in another way? Or is it really true emergency in which I have to use aggressive treatment? So use this scale. This takes into account the GI, liver function, CNS situation, the hyperthermia, the tachycardia, the congestive heart failure, presence or absence. And then in the lower end, you will see the scoring system. So cumulative score of more than 45 is highly suggestive of thyroid storm. Now, when you want to treat it promptly. And remember, you're going to work on different lines. You want to use medication that can block the synthesis of the thyroid hormones, like you're going to use mesamizole. But remember, this medication, they take longer than you expect to make an immediate effect in your case. So you give them, you start with them, but you don't rely on them because they were going to take days to start working. You can use Lugol. This can block the release of the thyroid hormones. Lithium, some people use it. I don't recommend it. Block of the conversion, peripheral conversion of T4 to T3, very helpful. This one is going to be effective. Use steroids, you can in severe cases. The use of beta blockers is very, very important, and also the use of supportive treatment to control the temperature. In severe cases, you can proceed for plasmapheresis, peritoneal dialysis, and use of charcoal plasma perfusion. And so, as I mentioned, supportive treatment, beta blockers, use drip. You can use antipyretics, use cooling blankets. You use cool IV fluids with proper protocol. So they need to be used very cautiously because they can induce also cardiac arrhythmia. So respiratory support is important, and also the use of sedation can also be helpful. Phenobarbital, as we mentioned before, it can also help the clearance of the thyroid hormone. I think that's all of the slides I have. I will inshallah stop here. And then if you have questions, you can add them inshallah to the question and answer session. I will inshallah remain in the session. I will yield to the inshallah moderator. Thank you for your time.
Thank you very much, Dr. Wasila. Alaikum salam wa rahmatullahi wa barakatuh. I think I will stop there.